Hello, I'm Dr. Kylie Mason, a clinician researcher who works at Royal Melbourne Hospital and also at the Walter Eliza Hall Institute. And one of the areas I'm particularly interested in is lymphoma. I'd like to give you an overview today of lymphoma, of what lymphoma is, of some of the ways we diagnose and treat lymphoma, and how people can live with lymphoma. Lymphoma is now the 6th most common cancer in Australia, and it's actually the most common form of haematological or blood cancer. Interestingly, the number of people with lymphoma has actually doubled over the last 20 years, and this is partly because with our ageing population, people are living longer of diseases that they might have otherwise died from, such as diabetes or heart disease, but also because we're becoming better at diagnosing lymphoma and associated diseases. Each year in Australia, there are approximately 5,000 people diagnosed with a form of lymphoma. And whilst the incidence does increase with age, lymphoma is a disease that affects not only people at the elderly end of their life, but also young people, including some children. Lymphoma is increasing, and it has been increasing over the last 10 or 20 years. Really, we don't have a clear idea as exactly why this is happening, and it is only found really in the non-Hodgkin's lymphomas, not Hodgkin lymphoma, or in the plasma cell neoplasms or myelomas, which, whilst not a lymphoma, also come from a lymphomatous type cell. One of the reasons we are diagnosing lymphoma better is there was a new classification system introduced in 2001 which classified diseases otherwise not previously known or thought to be lymphoma as lymphoma, but also that we've developed a large number of new diagnostic techniques over the last 10 or 20 years. Most people are diagnosed with lymphoma in the 6th or 7th decade of life, i.e. in their 60s, 70s, 80s. However, as mentioned before, this is a disease that often can have a peak in late childhood or adolescence, and again another peak in people who are elderly. Lymphoma is a cancer of white blood cells that live in the lymphatic system. These cells grow uncontrollably and form tumours. So unlike leukemia, which is a cancer of the blood where the leukemia cells are found in the bloodstream, lymphoma cells are actually found within the lymph node and form masses or enlarged lymph nodes. Most people are familiar with lymph nodes because they're what it becomes enlarged in children when they have colds and flus, for example, and people often feel lymph nodes as masses in their neck. However, in lymphoma, the lymph node cells affect and swell lymph nodes throughout the whole body. These lymphoma cells crowd out the normal cells in the immune system and affect the body in ways by not only causing problems by masses of tumour, but causing problems with the normal function of the body, both the immune system and other organs. Lymph nodes are generally found in clusters throughout the body, and they normally act as a filtering system for the body's fluid called lymph as it passes through. The cells in the lymph nodes, called lymphocytes, act to fight bacteria and viruses when they enter the system. These cells are particularly clever because they have a memory, and they're able to look at a bacteria or virus and see if it's something they've seen before, and then recruit other lymphocytes to attack this cell and destroy it. These bacteria and viruses we commonly see every day, and this is how lymphocytes and lymph nodes do their job. When we have an infection, the lymphocytes are recruited, they swell up the lymph nodes, and the lymph nodes become enlarged and tender, and this is a normal process. We see this most obviously in children, and many people will be familiar with children who've come home with large or sore lymph nodes, particularly in the neck where they're easy to feel. This is a diagram showing the major lymph node areas of the body. And whilst we often feel and see lymph nodes in the neck, as you can see here, they're throughout the whole body. Most commonly, we're able to feel lymph nodes in the neck, under the arms, in the groin, and also sometimes behind our knees. However, as you can see, the lymph node areas extend throughout the body, and there are many, in fact, we cannot feel, particularly in the middle of the chest, what we call the mediastinum, or in the abdomen, particularly deep in the abdomen, in the retroperitoneum, we would call it. The lymphocytes, as I was mentioning, are specific specialised white blood cells that fight infection, and you can see in the diagram here there are lymphocytes, 2 of them, which are the larger cells with the purple, what's called a nucleus, with a very thin rim of lighter purple or blue cytoplasm around the outside, as compared to the red cells, which are the other cells in the picture that don't have a nucleus. These lymphocytes are normally found both within the lymph node system, but also in the blood and bone marrow. They're actually made within the bone marrow but live in the lymph nodes in general. There are 2 main types of lymphocytes, the B lymphocytes and T lymphocytes, and lymphoma can affect both B and T cells. When we look at the different types of lymphomas, we can see that they arise from these lymphocytes, the cell of origin. We tend to talk about lymphoma in two major groups, the Hodgkin lymphoma and the non-Hodgkin lymphomas. By far and away, non-Hodgkin lymphoma is the most common. It's the sixth most common cancer in Australia, and it actually accounts for just over 4% of all cancers in Australia. This is the one we were talking about, the incidence increasing with age, and there are many, many, many different subtypes, which I'll touch on later. Hodgkin lymphoma, on the other hand, is far less common. It's only around 0.5 or half of 1% of all cancers, with only around 400 cases in Australia each year. Hodgkin lymphoma occurs in two general groups of people. In young people, particularly in late adolescence, so people from the age of 15 to 25 or 30 years old, and another group of people in their 60s and 70s. Hodgkin lymphoma has 5 broad subtypes. Hodgkin lymphoma is often called a Clayton's lymphoma, or a cancer that has a good prognosis and is easy to treat. However, for anyone affected with Hodgkin's lymphoma, it certainly is not the case. Hodgkin lymphoma is also the lymphoma that many famous people have had, in particular Delta Goodrum, and many people refer to it as the famous people's cancer, or for example. So it is a lymphoma that has some notoriety, but is in fact one of the least common forms of lymphoma. Non-Hodgkin lymphoma, however, there are over 50 different subtypes. How do we classify lymphoma? Well, we classify it by looking at the histology, or the appearance under the microscope, by looking at the characteristic of individual cells. So what we would actually do is, taking a biopsy of a lymphoma sample, we would stain those cells with various markers, and different lymphomas would stain with different markers, and it's this pattern that makes us think of a different type, or differentiate one from another. We also look at the genetic mutations within a tumour. So many tumours, lymphomas are just one of them, carry genetic mutations that allow a cancer cell to live and grow. We're able to examine these particular genetic mutations, and it's important to understand these genetic mutations are actually mutations within the tumour cell and not mutations within the rest of the person. So in fact, it's not that someone themselves has any genetic mutations, it's just that the cancer cells themselves have acquired these mutations that allow them to live and grow. And particular mutations are associated with particular lymphomas. Along those lines, we're also able to look at the molecular features of lymphoma, which again look at mutations within the tumour cells. And the other thing we look at is that different subtypes of lymphoma have different clinical characteristics and outcomes. Some occur more commonly in younger people than older people. Some might occur in different sites of the body. And all of these things help us to classify a particular lymphoma. When someone is diagnosed with lymphoma, it's all of these things will allow a doctor to formulate an answer as far as which subtype, and depending which subtype of lymphoma that someone is thought to have, will give us an idea as to what the best treatment for this lymphoma is, and indeed what the possible outcomes would be. The other way people will often talk about non-Hodgkin lymphoma is talking about the grade, or how fast the non-Hodgkin lymphoma might move. We'll often talk about indolent or slow-growing lymphomas that tend to have a low grade. They grow slower, so evolve over many years, and often display few symptoms, particularly initially. And some of these may not need to be treated at all, and certainly not need to be treated urgently. On the other hand, on the other side, we have some lymphomas that are very, very aggressive. These occur over a short period of time and tend to cause problems quite quickly, and often will need treatment somewhat more urgently. Lymphomas can occur anywhere in this range, from a low-growing to a more aggressive lymphoma, and anywhere in the middle. In general, the cause of lymphoma is unknown, and most people who have lymphoma, it's through no fault of their own, it's nothing they've caught, and lymphoma is not something that we passed on to other people. In general, most people who have lymphoma also are not genetically susceptible to lymphoma, and in fact, there is no more likelihood of their children, grandchildren, or anyone else in their family having lymphoma just because they've been diagnosed with the disease. However, there are some small groups of people who are at higher risk of lymphomas, and these generally are people who have low immune systems, either because they've had a transplant of another organ, such as a kidney transplant or a liver transplant, and on immunosuppressive medications. People who have infection with HIV, for example, or there are various rare infections such as Epstein-Barr virus. The virus that causes glandular fever can rarely cause lymphoma. There's also been cases of lymphoma that have been related to chemical or toxin exposure at very high dose, and also high exposure or frequent exposure to radiation, most commonly seen after nuclear disasters such as Chernobyl, for example. The signs and symptoms of lymphoma are incredibly variable, and this relates to the fact that lymphoma can occur in any of the lymph node groups or many of the lymph node groups throughout the whole body. Some of the common signs or symptoms of lymphoma are enlargement of the lymph nodes, and of course this can be swelling of the lymph nodes in any site, such as the palpable ones in the neck, under the arms or in the groin, or swelling of the lymph nodes in areas that we can't see, such as the abdomen. And whilst this might not cause symptoms when they're small, potentially these can block vital organs, such as block the drainage of a kidney, for example, causing renal failure. Other of the more common findings of lymphoma are what we might call the B symptoms, symptoms such as loss of weight, itch, sweats at night, and by sweats we mean drenching night sweats where people might have to change their bedclothes overnight. However, there are many common symptoms of lymphoma that appear to be symptoms of a cold or a flu, or in fact just fatigue or tiredness, and it's a constellation of these symptoms that makes the diagnosis in combination with a appropriate biopsy and scan results. Of the lymphoma subtypes, some are more common than others, and the commonest type of non-Hodgkin lymphoma, up on the top of the graph there, is diffuse large B-cell lymphoma. These lymphomas occur generally fairly equally in people of different nationalities, with white, black and Asian represented here on the graph. However, there are some disparities, but not many. Plasma cell neoplasms I'm not going to discuss today because they're generally known as myeloma. However, they are often counted as one of the types of lymphoma. To diagnose lymphoma, we do a number of diagnostic tests, and we also do tests that are called staging investigations. By staging, we mean finding out exactly where the lymphoma is, so we know where it is, so we can give an accurate information about how best to treat the disease, and also accurate information about the prognosis of the disease. One of the important things about staging a tumour, such as lymphoma, is that we also know where the lymphoma is when we start the treatment, so we know where to look to make sure that it's all gone once we've finished the treatment. Common tests that we'd perform include a bone marrow aspirate and trephine, which is a needle into the bone marrow to check if there's lymphoma in the bone marrow, which is very common in the low-grade lymphomas. Blood tests, scans such as a CT or plain x-rays, and sometimes a PET scan, which is a metabolic scan that lights up when there are evidence of tumour cells. This scan can actually be negative in the low-grade lymphoma because the lymphoma cells in low-grade lymphoma are not very active, whereas the high-grade lymphomas are very active, and it's the very active cells that light up on a PET scan. We might also do heart tests, lung tests, for example, checks of the urine and the kidneys, all depending on the type of lymphoma and where the lymphoma is. Staging, as I mentioned, is just deciding whereabouts lymphoma is, and we would talk about the stage of lymphoma in a classification that was previously known as the Ann Arbor classification, and basically it's a staging from grade 1 or stage 1 through to stage 4. Stage 1 would be one lymph node in one region or one organ, so for example a group of lymph nodes in the neck here. When there's two or more lymph nodes areas involved, but they're on the same side of the diaphragm, and the diaphragm being the main muscle that divides the body basically into half, just under the lungs and above the abdomen, we would talk about that as being grade 2, stage 2, above or below. Stage 3 is involvement on both sides of the diaphragm, and stage 4 is where there's involvement of an extranodal organ. So this is, for example, where an organ is involved like the spleen, the liver, the kidney, or the bone marrow. Because of the particular nature of lymphoma, and because lymphoma occurs in many different sites of the body very commonly, as well as it almost always involves the bone marrow, particularly in the low-grade lymphomas, a diagnosis of stage 4 lymphoma is very common and in fact normal, and not something to particularly worry about. We would also add a differential of A, B or E to the stage. A would be no symptoms, B would be symptoms such as I described before, such as the weight loss, night sweats, fevers, and E is where there's involvement of an extra hematopoietic or extra outside the lymph node organ, but not the bone marrow. When we would talk about a stage, therefore, we would say someone had stage 1A, describing that they might have a lymph node group in the neck with no other symptoms, or say 4E, where they had involvement of multiple sites, including organs, and to say a deposit in a kidney or a liver, for example. A higher stage is not necessarily a bad thing or a worse prognosis in all lymphomas. The prognosis, or how well someone is likely to do with treatment, is incredibly variable and quite individual across all lymphomas. We would talk about prognosis as a guide only, and it allows us to estimate how well someone or one person's disease might respond to a particular treatment. But as each lymphoma is different and individual, each person is an individual, and the type of treatment that we're able to deliver and talk about with each individual is important to discuss with your doctor. Many lymphomas can actually be treated or watched for many years and don't actually affect a person's lifespan or how long they live. They're diseases that people can live with, just like diabetes or arthritis that people might live with for some time. And in fact, they don't actually shorten a person's lifespan, whereas other lymphomas, particularly aggressive ones, might do that if they don't respond well to treatment. I've listed a couple of common terms that you can read that we talk about, or doctors might talk about when they're talking about lymphoma, and I think the ones that are most confusing or common in some ways are remission, where we talk about the fact that we can't see any more of the lymphoma on our testing, and relapse, which is the disease returning. When a disease relapses, it can also transform, and some lymphomas can transform into a more aggressive form of lymphoma, or sometimes even a leukemia, which is where we see cancer cells in the bloodstream. Other common terms are listed here, and they're things like partial remission, where the lymphoma might respond partially to treatment but not fully, or resistant or refractory disease, where we find that disease in fact doesn't respond at all to the treatment. How your doctor might manage lymphoma depends on a large number of things. Only one of these is the lymphoma itself. One of the main things is actually the patient themselves, the general age of the patient and general health. For example, we would treat someone who is very young, for example a child, very differently of course to someone who is very elderly and has a number of other medical conditions that might affect the medication that they will tolerate and be able to give. The management of lymphoma can vary across from watch and wait, which is where we would watch and carefully do tests and examine patients regularly to check for progression of lymphoma, right through to chemotherapy, radiotherapy, immunotherapy, stem cell transplantation or bone marrow transplantation, and clinical trials. And I'd like to touch on some of these now. Watch and wait is quite a difficult concept with lymphoma, and it is very difficult sometimes when you've been given a diagnosis of a cancer such as lymphoma and the doctor says to you, in fact, we're not going to treat this cancer, we're just going to sit and watch how it progresses over time. Many studies have been done over time demonstrating that with lymphoma and particular types of lymphoma, for example follicular lymphoma, one of the commonest low-grade lymphomas, there's actually no advantage to giving high-dose chemotherapy at the start when people are first diagnosed unless the disease is causing particular problems at that time. In fact, the side effects of treatment can actually shorten someone's life more than the lymphoma is going to if it's not treated at that particular time. However, this is a difficult concept and something that it's important to speak to your doctor about and address any concerns you might have about why your lymphoma in particular doesn't need treatment at this particular time, if this is something that your doctor suggests is how your lymphoma is managed. There are no side effects to watching and waiting, and I guess that's one of the biggest advantages of it, is that first do no harm, and by doing nothing essentially except watching, no harm is often being done. And it's important that patients who are being watched and waited are seen regularly by their doctor, generally at roughly 3 monthly intervals. However, if the lymphoma is particularly slow growing, it may be longer than that. This is generally only applicable to the low-grade lymphoma, but is actually a very common way that we would manage many people with lymphoma. Another common and probably the commonest way to treat lymphoma is with chemotherapy. Chemotherapy is a word that we use to say that they're drugs that treat cancer, and these can be medications or drugs that we use to treat lots of other diseases as well, although some are quite specific to cancer treatment. They can be given as tablets, injections, injections under the skin, such as you might give an insulin type injection, or can be given more specifically as injections into the spinal fluid, for example. Chemotherapy is often delivered as an outpatient, so patients coming into a day centre in a hospital or in a day unit to have their chemotherapy. In other examples, patients might have their chemotherapy as an inpatient having to stay in hospital for a number of days associated with fluids and other interventions that might be required. Often with chemotherapy there are side effects, and the side effects of chemotherapy are very specific to the particular drugs that are being used. However, there are some general common ones. People may require additional medications to combat some of the side effects of chemotherapy. So in fact, the medications someone on chemotherapy is on, not just the chemotherapy, but also other associated medications to prevent other problems. Most chemotherapy drugs work by killing rapidly dividing cells, and in general cancer cells are rapidly dividing cells. Even the low-grade lymphomas are dividing more rapidly than most cells in the body. However, some cells in the body also divide quite rapidly, and these are the cells that are killed by what we would term as collateral damage or damage by the chemotherapy. I like to divide these into 3 main groups of cells. These 3 main groups of cells are the hair cells, and most people having cancer chemotherapy will lose their hair, although that's not always the case. The mucosa, or the lining cells of the mouth and the gut, and also the normal blood cells. So the side effects of chemotherapy can generally be grouped into problems that are caused by the damage done to these normal cells. So the side effect of hair loss, the side effect in the mouth and the gut of mouth ulcers, of nausea, of diarrhoea, and also the side effect of the destruction of the normal blood cells. The normal blood cells being the red cells causing anemia when they're low, the platelets being the sticky cells in the blood that help the blood to clot, so the risk of bleeding if they are low, and the white cells. The good white cells fight infection, and one of the commonest and most debilitating and in fact risky side effects of cancer chemotherapy is often, with high-dose chemotherapy, long periods of time with low white cells that leave people very vulnerable to infection. Sometimes there are longer-term side effects of chemotherapy, and it's important to discuss with your doctor initially what these might be. Some examples can include a loss in fertility, and this is particularly important in the younger people, of course. Other side effects might be side effects affecting the heart, such as a disease called cardiomyopathy, or in the long term, what we would term as secondary blood disorders or cancers. Most of these long-term side effects are very rare. However, it is important to have a broad understanding that these might be risks that are undertaken with chemotherapy treatment. Fertility loss can be quite common, however, with some types of aggressive cancer treatment, and it is important to discuss this with your doctor, preferably before treatment, but even during your treatment, to discuss if there's anything that can be done to preserve or maintain some fertility if possible. Radiotherapy is also an important part of cancer treatment, particularly lymphoma treatment, and is indicated particularly for where there is one big mass or tumour with lymphoma. Radiotherapy, unlike chemotherapy, only targets a certain area of the body and not the whole body. Hence, if you have lymphoma or leukemia, for example, spread throughout the whole body, giving radiotherapy to one particular area is of course not going to cure the lymphoma. Radiotherapy can be very helpful, however, where you do have one large tumour mass and the rest is